It's great to welcome back to the program today Dr. Isaac Bogoch, who's an infectious disease physician and scientist based at the University of Toronto and Toronto General Hospital. Great to have you back on.
Thanks for having me back.
So we spoke recently, but everything has changed since we spoke. I mean, the degree to which this has continued to spread. As someone who works in this field, are you surprised by the trajectory since we've spoken?
Sadly, no. We knew that this was going to spread around the world. We knew that countries that were reporting cases were going to have a growing burden of cases, and then we knew that countries that didn't yet have cases were going to start to see cases very shortly. And we take a step back and look at the 30,000-foot view now. Most of the world is affected, and sadly, some places are more severely affected than others.
So let's start there. I have a bunch of questions, including from my audience. I'm not going through them in order of importance, but just to start somewhere. We're seeing very different death rates in different countries, and a lot of ideas have been posited that there's two different strains of different lethality, although I've not seen good evidence for that so far, that the populations are older or sicker in some places. What do we know so far about the drastically differing death rates?
Yeah, so short answer is that we don't know as a medical and scientific community, but we have lots of different theories, and I think this will be fascinating when the dust settles, and a year or two from now we have better answers. So I still think we have to remain humble that we don't have all the answers. Having said that, I think there's several factors that come into play here. This business of having several strains of the virus, I'm not entirely sure that's going to play out. I don't think that's going to pan out in the end. Viruses mutate all the time. It doesn't necessarily mean that it's more virulent or more deadly than another virus. And there's likely multiple strains of this virus as it spreads through different continents. It doesn't necessarily mean that those viruses will cause different severity of illness. So that's one point. The second point is we know that the populations that this virus is affecting are different. And we definitely know that this virus has more severe outcomes in people who are over the age of 60, and especially in those over the age of 80. So elderly populations, unfortunately, are getting significantly impacted by this infection. And we've seen, for example, places like Italy, where there is sadly, this tremendous death toll, and this is vastly overrepresented in elderly people. And I think the third major factor here is how robust a healthcare system is and how robust a public health system is within a country. And we've seen countries, for example, like South Korea, Singapore, Hong Kong, Taiwan, where they have fantastic clinical abilities and clinical capabilities, and also a very robust public health system. And they really implemented strong control initiatives earlier on in the epidemic. And most of those countries, I mean, everyone's coming out battered and bruised, but they're coming out less battered and bruised compared to most others.
So to follow up on some of the discrepancies that we're seeing before we move on to testing, early the data from China suggested a significantly higher death rate for men than women. And it was suggested that for cultural reasons, men are more likely to smoke in China, and that might be the explanation. But it looks like that discrepancy is persisting in other countries without the cultural smoking differences. What do we know about that so far?
It's unclear yet, and I don't have a good answer for that yet. And that is obviously one of the top questions is, what are the actual risk factors for having a serious infection and death? We already know that age is a risk factor and that medical comorbidities are a risk factor. If you're sick to begin with and you get this infection, you're more likely to have a more serious infection and sadly more likely to succumb to this infection. But sex and gender are still unclear as to how that really manifests with this infection. And by virtue of being a male, is that also reflective of having a greater, depending on the country, a greater probability of having hypertension, diabetes, smoking, or is there just something about being male that puts one at greater risk of having a more severe outcome? It's not yet clear.
So let's talk a little bit about testing. We know that here in the United States, we have been drastically under testing, so no surprise. As more testing rolls out, the number of cases start to increase dramatically, but probably still drastically underrepresenting the real number of cases. We are hearing from some governments that there's really no reason to test people without symptoms. There's no reason to test people who are not serious enough to be in the hospital. I want to hear your thought about that in general, but then also more specifically, most of the tests in the US are not antibody tests, which wouldn't tell us if someone has had and has recovered from the disease. Would the issue of testing everybody be different if we were using an antibody test rather than a pathogen test?
Okay, so there's several excellent components of that question that I think need to be addressed. The first component is the degree of testing. And I agree with you completely. There is tremendous under-testing, not only in the United States, but actually in most parts of the world. So the actual figures that we see, the numbers that are reported, are gross underestimates of the true burden of infection in just about anywhere in the world. Now, some places have more access to diagnostic tests than others. For example, if we compare the United States with South Korea, the United States is testing relatively fewer people, significantly fewer people, compared to a place like South Korea. So, so South Korea's numbers are probably more of an accurate reflection of the true burden of this disease in that country relative to the numbers coming out of the United States. But we get it. We all know that. And there's various reasons for why some countries have imposed broader diagnostic testing than others. In the United States, again, these are completely apolitical statements, but there was just some incredible bureaucratic, logistic, and economic hurdles that got in the way and that continue to get in the way of providing wide diagnostic testing. And that certainly has set the United States back in their fight against the COVID-19 pandemic. And it's really unfortunate to watch that unfold in real time. But by no means are other countries perfect. There's many, many reasons why places just have not tested broadly. The next point I think that's important to address is the utility of the test that we're doing. And I think we have to be mindful of the question we're asking. In a clinical sense, one of the questions we ask is, do you have this infection, yes or no? Because that is going to impact our clinical management of that individual now and also in the coming days. So the testing that's being done now, which is a PCR test, which basically answers that question: is that virus present in you? Yes or no? Are you infected? Yes or no? That's an extremely important test, and that's the appropriate test to be doing right now. And it's not the most comfortable test. They do what's called a nasopharyngeal swab, where they take a big swab and they stick it all the way into the back of your nose. People think it's just like a little thing in the front of their nose. No, anyone that's had this knows that it's not the most comfortable test to have, but you got to get a good sample, and that's the way to do it. And that's the appropriate test to be doing, because that answers the question, yes or no, am I infected with this virus? And that will impact clinical management of that individual now and also in the foreseeable days ahead. What you're referring to as well is what's called an antibody test, which basically asks the question, have you ever been infected with this virus? Yes or no. It doesn't tell you, are you currently infected with this virus? It's, have I ever been infected with this virus? Yes or no. Antibody tests are typically blood tests, and there are many groups that are developing these antibody tests to determine if someone has ever had an exposure to this particular coronavirus, yes or no. These tests are hard to develop because, as you can imagine, there's lots of different types of coronaviruses. We have the common cold, which there's 4 different types of coronaviruses that are implicated in the common cold. Plus, we have this COVID-19 pandemic. And, we've heard about MERS and SARS and other coronaviruses as well. So one of the issues is there cross-reactivity when we're looking for this specific coronavirus versus other common coronaviruses that cause the common cold? I think there's a lot of research teams that are developing these serologic tests. These are excellent tests to have. I think at the end of the day, it will be very, very valuable to use those tests widely to see truly what proportion of the population was affected by this COVID-19 pandemic. But, in terms of clinical management right now, I don't think the serology test would be nearly as useful as the PCR test that we're doing right now.
Yeah, I mean, I guess where I'm thinking about it would be, imagine that you tested large portions of the population and found that, imagine it's 1.5 or 2% of the population had the antibodies. Would that be useful from an infectious disease perspective in thinking about the trajectory, so to speak?
Yes, absolutely. So I just want to distinguish two sort of overlapping Venn diagrams of clinical care and public health. And of course, these overlap significantly. But from a clinical standpoint, that antibody test may be a little bit helpful, but the PCR test would be extraordinarily helpful. It's also available, in decent labs. It can be available in a matter of hours. So the PCR test is valuable from that standpoint. But when we're looking at, populations, and, as you point out, if we knew that one population had a much greater exposure to this virus compared to other populations, yeah, it's also extremely valuable from a public health standpoint, because that can help drive policy, that could help guide public health policy, that could drive, vaccine efforts when a vaccine is available, that could also drive more focal public health initiatives such as the physical or social distancing measures that we're all talking about and employing widely these days. So, it's certainly valuable information, but I think from a public health standpoint, the serology test would be more valuable at this point in time. And from a clinical standpoint, the PCR is a little bit more valuable.
We're going to go to a break on our TV and radio show and podcast with Dr. Isaac Bogoch, but we'll continue talking on our YouTube channel where you can find the remainder of our conversation. So then we get into the social distancing methods and questions that are now coming up about, should you go get groceries or have them delivered? And how do you weigh or manage the exposure of being in a grocery store versus someone you don't know touching your fruits and vegetables and this type of thing? At what degree, at what level of granularity do these decisions make an impact, so to speak?
Yeah, I mean, obviously, these are very challenging questions because it's hard to micromanage every potential situation that may arise. But I think if people are mindful of the general principles, we'll all be okay. And the general principles are, physical distance. I know we're talking about social distancing, but I think it's important. Words do matter, and I think we're switching to using a physical distancing measure because social interaction is extraordinarily important, and especially important during these very difficult times where we are physically separated from one another. So when we're talking about these, physical distancing measures, I think as the public health officials have been saying, keep it to about 6 feet if possible. Of course, we can't micro-regulate every potential interaction that may happen. Of course, people need to go out and get groceries and, fill their car with gas and, still live their lives with, as much normalcy as possible. But of course, we also have to abide by these rules to ensure personal safety and also for public safety. So, grocery stores, many grocery stores have adapted to this as well. And you can tell that many people are going to grocery stores at off hours. Some grocery stores I've seen have taken very creative solutions. In the lineup, they put tape on the floor so that they know that people will stand in line and be separated by an appropriate amount of space. Many grocery stores have actually put some hand sanitizer out. And there's also the onus on the individual. If you're going to go to a grocery store or going to a public place to get, essential items that you may need, bring some hand sanitizer. If you're in touch with any high contact surfaces, let's be mindful of that. Wash your hands with soap and water or use hand sanitizer. Be mindful about not touching your face. And of course, wash down any surfaces in your home as well with the appropriate bleach-based solutions that are recommended. So there's lots of things that we can do that essentially mitigate our risk of getting this infection while we practice our physical distancing measures and simultaneously while we go about our day-to-day lives and try care for ourselves and our families.
So last time you were on, we talked about the question of droplet versus aerosol is a gradient, so to speak. It's not just it's one or the other. As that applies to, for example, people in Boston, as the weather has been nicer, are distancing physically, but are going to parks and bike paths, for example. And for the most part, people know you kind of stay separate as you pass each other. But invariably, when the bike path is 3 feet wide, runners are going to pass each other in the opposite direction, and they're going to be breathing, as people tend to do when they are running. What is the risk of an infection in these outdoor scenarios? I've read it's as low as 1%, but it's like, what does that really mean? Does that mean if you pass 100 people, you infect one of them?
No, I mean, I think there's a few points here. One is that it's great to hear that people are getting outside because truly we're not locked in our homes, right? And these are tough times, and if we should be encouraging going outside, getting fresh air, getting exercise, but of course still adhering to these very important physical distancing measures. And again, we can't micromanage every situation that may arise. And of course, joggers or bicyclists might pass each other on the path. And for the fraction of a second that you're passing each other on the path, I think the risk of transmission if one person is infected is like exponentially small. This is transmitted through direct contact or through droplets. So if someone's infected and like there's the most unlikely of unlikely scenarios that they're coughing in your face as you're running or biking by, that would be a problem. But I think that's a pretty unlikely scenario. The other thing too is if you're sick, you shouldn't be outside in the first place. If you're sick, all the recommendations are stay at home and self-isolate for a period of 14 days. So truly, if people abide by the public health rules, the public health rules to really prevent transmission in the community, we'll be okay. It's just a matter of people buying into these ideas.
So that goes directly into the question of the folks without symptoms or almost no symptoms. I've seen one study that says 15 to 18% of cases have no symptoms. There's an Icelandic study that found half had no symptoms that they could at least be aware of. Where are we on that? And don't those numbers make it much more challenging to say, if you're sick, you shouldn't be out? Because there may be, NBA players who say, I've tested positive, but I always felt completely fine, as an example.
Yeah, there's a few points with that. So I think the helpful phrase is subclinical, because if we say the term subclinical, it really means that people are, whatever they feel, either nothing or something extraordinarily mild, it's below the detection of the healthcare system. You're not unwell enough that you're going to stop doing what you're doing. You're not unwell enough that you're going to go seek medical care. And that's the most accurate term, because it's a broad umbrella term that really captures everything under that. The term is subclinical. And therein lies the problem. Because there is such a large burden of subclinical infection, there are lots of people who just don't feel that bad, who are walking around with this infection. And these are individuals who are likely contributing to the spread of this infection unknowingly in community settings. And this is why we have a pandemic. This is why it's extraordinarily challenging to control this infection. And in the same breath, this is why we truly need to adhere to these physical distancing measures. Because if we truly spread apart, if we're truly mindful about hand hygiene, if we're truly mindful about not touching our faces, if we're truly mindful about washing down high contact surfaces like door handles and elevator buttons, we can block many of these chains of transmission. And it's because there's so many people out there who are subclinical, who just have mild to no symptoms, that are facilitating transmission in community settings. If we can block that by really spreading out.
Last thing I want to ask you about, we for the last 10 or 14 days have been talking about everything from remdesivir to Avigan, the possibility of chloroquine with or without azithromycin, HIV drugs with or without interferon. The WHO is now starting a pretty large clinical trial that doctors all over the world are going to be able to opt patients into. If you had specific thoughts about any of these, I would love to hear them, but more likely, I think it would be interesting to hear how quickly might we start to figure out which of these is a better path rather than a less good path, and sort of what the process will be.
Yeah. So, got an hour? I mean, this is fascinating, and it's just wonderful to hear that there are so many potential. You got to be careful with our words. Potential treatment options. And I would add that these aren't just treatment options, these are also being studied for prophylaxis, meaning if potentially someone was exposed, could they go on one of these medications and avoid getting infected in the
Right.
first place? Now, there are well over 150 clinical trials that are testing these various compounds now. The key thing here is getting quality data. There's a lot of small studies that have made huge waves. For example, this chloroquine and azithromycin, these are great tiny little studies that are not conclusive, but are what we would call them hypothesis generating. Like, hey, maybe there's something here. We should look into this further. But the real studies are enrolling patients now, and these are what we would call prospective studies that are blinded, meaning the people who are getting these medications don't know which medications they're getting. The clinicians administering the medications don't know which medications they're administrating. So they're placebo-controlled or blinded and prospective studies, which is essentially the gold standard for testing the efficacy of various treatments. And when we have this quality data, we will be able to make much more meaningful suggestions on how to treat and prevent this infection. How long does it take? Surprisingly, not as long as people would think. Let's put it this way. We'll have this data available well before a vaccine becomes available. And these clinical trials are actively recruiting patients. And, I would be hopeful that we might start to see early results in the coming 6 to 9 weeks, because sadly there's no shortage of patients, and many of these trials are actively recruiting, and to have more definitive results in probably closer to 3 months.
So on the blinding thing, the WHO trials say they will not be blinded, although some of the other ones are. Arthur Kaplan from NYU said it's not ideal for them not to be blinded, but given the circumstances, it's still a good trial. What does that mean? How do you balance the lack of blinding with the sort of need to start doing this?
Yeah, I mean, I think we should point out too that there's so many trials that are ongoing, and each trial will have its own design, and each trial will have its inherent strengths and its inherent weaknesses. In a perfect world, many of these trials would be blinded, which just adds a degree of robustness to the trial and the confidence that you have when you're stating the results of your trial, that there's no unintended bias from patients or from clinicians who are administering the trial that gets bled into the trial that way. But by no means, if the trial isn't blinded, it doesn't mean that it wipes out the results of the trial. It's just, it's not a perfect design. That does not take away from the trial at all. And in fact, any trial, any prospective trial is extremely welcome at this time. And, we're going to be hanging off every letter in the printed manuscripts that come out from this. And we're going to be hanging off of every word of the individuals who are recruiting patients for these trials, because we want to know, are they working? Are they not working? And this is truly going to impact the clinical management of many, many, many patients.
Absolute last thing. So with the chloroquine azithromycin trial, a lot of people are saying, why an antibiotic for a virus? My understanding is that although it is an antibiotic, there are studies that seem to be good studies that show in lung cells it functions like an antiviral. Is that the right interpretation?
Short answer, we have no idea. It might be. It might be. There also may be what we would call immunomodulatory effects as well. So this is very theoretical. First of all, we don't even know if this works. Let's be clear. That study had, I think, 30 patients in it with
30.
a small control group. Like, it's pretty hard to make definitive conclusions from that study. It's great that it was done. It's hypothesis generating. It's sort of like, if we think about it in volleyball terms, that's the bump, and now we need the set and the spike. So that's the very, very, very early part. But like, we can talk about theoretical mechanisms. I'm not sure it's going to be all that helpful. Let's see if this works or not with the larger studies.
We will indeed. We've been speaking with Dr. Isaac Bogoch, infectious disease physician and scientist from the University of Toronto and Toronto General Hospital. Really appreciate your time once again.
Oh, thanks for having me back on.